Oh, good morning, everyone. It's my pleasure this morning to introduce Dr. Larry Dean. I am sure all of you know Larry well, but I'll just point out a few salient points. From the title of Larry's talk, you can see that he has developed perhaps not a new interest, but a sort of focused interest on how healthcare delivery is done, and particularly here at the University of Washington. Many of you may know, hopefully know, he took on a new role in UW medicine recently around clinical clinical products and smart innovation, which is really to look at the way we purchase, utilize products, particularly in some of our high-end places such as the cath lab, the ORs, and so on, and some of the faculty have sort of joined him in that committee. You know, this is also reflected nationally in the roles that he's taken on as the president of SCI, and more recently on the ACC Appropriate Use Committee and task force that is coming out regularly with guidelines for cardiologists about appropriate use of various modalities that we use. So with no further ado, I'd like to have him come up, and the title of his talk is American Healthcare System, How We Got Here and Where We're Going.
So thank you, Rob. It's a pleasure to be, can you hear me okay? Okay, it's a pleasure to be here this morning. As Rob alluded to, as I started thinking back on my career, this is an area that I've actually participated in, kind of fell into it, I guess, for lack of a better way of describing it, when I started managing cath labs at my former institution, and then got involved more in hospital-based economics. So I've been involved in this for quite some time, and really was one of the reasons I came back to the University of Washington, having been a resident here a number of years ago. Also, the thing about this presentation this morning, which you will find, I think, hopefully interesting, perhaps, is that there's not going to be a case report, a case presentation. There are no p-values. There are no Kaplan-Meier curves. There's no linear regression, meta-analyses, or any of that. So we're going to talk about the economics of healthcare, particularly as it focuses on hospitals and physicians. And at the end of this, I'm going to give you some thoughts about where we're going. I wish I knew where we were going, but I will give you some of my thoughts about this. So, obligatory conflict of interest, I don't have any for the fellows and faculty who take boards. I'm on the cardiovascular board writing committee, and nothing in this presentation will be on those boards. I can assure you of that. So, lecture outline here. We're going to talk about how we got here. And to talk about that, we have to talk about the history of healthcare in the United States. And I'm not going to go back to the 17th century or something like that, or 18th century, but we will go back over 100 years to look at this. Talk about the current burning platform. It's not the current burning platform. The problem of the cost of healthcare in the United States has been an issue for many, many years. A little bit about how we get paid, because it's important to understand how we get paid, both hospitals and physicians, to understand some of the malalignment of the way we get paid in the United States. Some future new payment models that are on the horizon, matter of fact, occurring currently. And you get into a little bit of an alphabet soup as you start talking about this. When you start dealing with the government, just like the military, there are initials for almost everything. And we'll cover some of that. And then in conclusion, as I said a moment ago, a little bit about where I think we're going to be going here, at least in the short term. So to remind everyone in the room, in 1847, the AMA was established. So again, many, many years ago. And then we had a whole group of things that occurred in the early part of the last century. AMA in 1910 had about 70,000 members. We had the Flexner Report looking at medical schools and education of medical students. Came out in 1910. That had an impact. In 1904, there were about 160 medical schools in this country. A decade or so later, 66. So a lot of medical schools in this country closed around the findings of the Flexner Report. In 1913, the American Association for Labor Legislation, sort of the early work with labor unions, comes out and develops a conference actually on what they called social insurance. And this is kind of the first time, at least in the United States, where this concept of having healthcare as part of our social construct was really discussed. But then things come along, and you'll see a pattern here. Things come along to derail the conversation a bit. 1917, of course, before that's when World War I actually started. The United States enters World War I in 1917, and that sort of stops a lot of the conversation about healthcare reform. So, 1928, we're going to pick it up here. General Motors reaches out to Metropolitan Life, a life insurance company, to say, hey, we need some coverage for our workers. This is where this concept of insurance as part of your workplace or as a benefit to employment starts being discussed. And it's about 180,000 workers at that point. But what else happened? What happened in 1929? The Depression, right? So things change. So these conversations start and then something happens to derail them a little bit. But in 1929, Blue Cross was established actually in Dallas, Texas. And here was the deal. If you give me 50 cents a month for a year or $6 a year, I will cover up to 21 days in our hospitals in Dallas. And it was really directed towards the teachers in that community. So that's, again, a prepaid notion. In other words, you give me $6 and I will let you have 21 days in the hospital. Then Blue Shield, a year later, Blue Cross was established for hospital reimbursement and economic reimbursement, and Blue Shield was established for physician reimbursement. The other thing that's playing in this whole conversation is the turn of the last century, you went to hospitals to die, basically. And now we're developing in this early part of that century the ability to treat various diseases, surgical procedures, and all those kinds of things, which you go from 50 cents to, or $6 a year to get you 21 days in the hospital, and it's getting more expensive, the things that are being developed. So that's the thing that's playing in the background here as well. In 1935, FDR shepherded through Congress. The Social Security was established at that point. Along with that was actually a proposal for universal health care, but it did not make the cut. And so all we got out of the 1935 effort was Social Security, a very important part of our country, but that, again, was initially tied with health care as well. In 1938, another famous name pops up, and that's Henry Kaiser, obviously Kaiser Permanente, at least the beginnings of that. And again, this was set up as a prepaid plan for his workers. So again, we're back to the economics of this being driven by where you work and who you work for. Is it GM? Is it Kaiser building ships, etc.? So these early notions of this. Okay, 1941, again, this is in the 30s, and now something else happens. 1941, the United States enters World War II. At that time, the administration, FDR, put wage and price controls so that inflation didn't increase as we were trying to produce all the ships and tanks for the war effort. And so to attract potential employees, all companies could do, they couldn't have to offer them more money, but they could offer them benefits. And one of the things that they started offering were health benefits. Again, this notion that your health benefits are tied to what you do and where you work. 1945, FDR dies in office, 1945. Truman offers actually a national health plan, and it's really interesting because it was denounced in the House of Representatives as a communist plot. Fast forward to today's conversation. So a lot of this is not new. So we're going to start talking about the cost of delivering health care. In 1950, healthcare was about 4.5% of the gross domestic product, of GDP. 1965, we finally did. President Johnson signed into law the Medicare and Medicaid provisions. So now we have health insurance for a certain populations that are paid for basically by the government. 1970s, healthcare was 6.9%, so it's gone from 4.5 to 6.9%. 1973, Richard Nixon actually sort of codifies HMOs. What is it? What are the requirements, et cetera, et cetera. And interestingly, President Nixon, who was Republican, had the notion of having universal, or at least everyone being covered by health care, and that was in 1974. I remind you what happened in 1974. He resigned as President of the United States, and that was the end of that conversation. So again, something else to interrupt the conversation about health care and how we provide it in this country. 1980, 8.9% of GDP, health care. 1983, things were getting, the increases in the cost of delivering health care were rapidly escalating, and Reagan decided to change the way hospitals were paid. Hospitals used to be paid, I use all this equipment, do all these things to you, here's the bill to pay me for what I did. What happened in the 1980s with Reagan is he said, no. Hospitals are going to get paid for an episode of care. If you come into the hospital with heart failure, you can do whatever you want to with that patient. You can do 6 echoes and 5 caths. You're going to get one payment for that encounter. Okay? And that's the beginning of this concept. It was developed, again, to try to rein in the cost of health care. What did it do? Not much. Health care is 12.1% of GDP in 1990. The Clintons, again, they try to reform health care. And if you start looking at the Nixon proposal and the Clinton proposal and the ACA or Obamacare, they are very similar, actually. There's not a lot of difference amongst those. So the Clintons started in 1992, again, because healthcare costs are growing very rapidly to try to do something about that. They failed. Fast forward a few years later, 2000, healthcare is 3.3% of GDP. 2010, in March of 2010, what's called Obamacare, or the Affordable Care Act, was passed, the ACA. And then in 2016, $3.3 trillion, or about 19 or 20% of the gross domestic product of this country, is in healthcare. So again, despite all these things that were attempted, healthcare costs are increasing. And these are societal costs. Of course, there is a cost to the individual as well. So it's a product of, as I mentioned a moment ago, the need to have healthy, productive workers. That's really the way this started. If I don't have a worker who can come to work and build my ship, then I have a problem. And that's what was really the underpinnings of this. As I mentioned a minute ago, our ability to provide advanced care. I mean, we've developed all kinds of techniques, and we have to pay for that some way. In 1890, you went to a hospital to die, as I mentioned a moment ago. The cost of providing that care, again, things have become more expensive. The technology has been developed over all these years, and the cost of delivering the care has gone up. And I mentioned a moment ago the vagaries of war, national, international tumult, wars, stock market crashes, presidents resigning, all kinds of things have impacted this. The need to provide care to the elderly and retirees, again, part of the Social Security acts that have been passed. And then, quite frankly, politics has been playing a major role in all of this. Again, it's a communist, 1945, it's a communist plot to consider universal health care in the United States. And it continues to this day. So before we get into this, you need to understand a little bit about the terminology. And so this is Hospital Finance 101. Everyone, I think, in this room probably understands that when you go to a hospital and there are certain charges, the insurance company does not pay those charges. They pay a discounted rate of those charges. So if they charge $1, let's say the hospital gets 40 cents of that. Okay? So there's no connection between what it actually costs the hospital. It's just a percentage of their charges. Revenue is what we actually get paid. The direct cost is the cost of providing that care. In other words, a stent, an echo, a stress test, etc. Then we have the indirect costs. Not in this building, because we're past the double doors, but if you go in the hospital, somebody's got to pay the electricity bill and the water bill and all the other things that are common to the providing that care in that space to make it work. The margin is what we have left to spend, what we can invest in our practice, what we can invest in buying new equipment. And then the thing that's becoming more and more discussed right now is this notion of value in healthcare. So what does that mean? Well, value, this is the way it's defined, is quality divided by cost, is the basic equation. So there's two ways to increase value. There's several ways to increase value. You can decrease cost and maintain quality. You can increase quality, maintain cost, or you can increase quality and decrease cost. Those are the three ways to impact value. At the end of the day, value is what we're paying for that particular product, right? This gets, if you break it down a little bit further, it's the outcomes. If you look at the quality plus the patient experience, which is being more and more discussed nowadays, and the cost of these direct and indirect costs that I talked about a moment ago, the actual cost of providing the care. But turning our attention back to the cost of healthcare, most of you, I suspect, have seen a slide like this, if not this exact slide. And this is the total health expenditures in the United States as a percentage of the gross domestic product. As I alluded to earlier, in 2015, it was about 18%. This is rounded up to 20% of the gross domestic product of this country. What does that mean? Just to give you a little bit of an idea, in 2010, it was $2.6 trillion. 2016, it's over $3 trillion. And that's just smaller than the entire German economy. So this is a lot of money. What does it mean when you break it down? And some people don't like these slides, but at least in 2016, the average cost in the United States for your health care per person is about $10,000. If you look at the other countries here, Switzerland's next in the line, but it ranges all the way from about $4,000 to about $8,000. Now, Switzerland has a private-public, it's not quite like the rest of Europe, where it's all basically publicly supported. So in Switzerland, you're required to have insurance at birth, basically. And if you live in Switzerland, to have insurance individually. Now, there is support from the government for people who can't afford that, but nonetheless, it's a private insurance-based product in Switzerland. But you can see there's quite a difference in comparing European countries to the United States. Well, what impact does this really have? Now, this is, I think, a telling slide. In the blue and black down here, you have overall inflation, and the blue is workers' earnings. Pretty reasonably flat, and this is a cumulative increase over those years between 1999 and 2017. But if you look in the orange, that's the family premium. That's the increase in the premium that the average family in the United States is paying. And then the other thing that's interesting on this slide is the worker contribution. In other words, people are being asked to contribute more to their health care than what they have done in the past. And those are both rising far more rapidly than their earnings, for example, or inflation in this country. So I think we have a problem here. That's not really sustainable. If you look at it a different way, this is looking, okay, what's the payoff basically? Life expectancy, is sort of a gross tool. It's like mortality, but, essentially. So, there are other ways of looking at this, but if you look at life expectancy, what are we getting for that increased cost to our system? Well, Japan has a higher life expectancy than we have. We're on the bottom of this. Germany, et cetera, Switzerland's second. So we're not getting a lot of payoff for that significantly increased expenditure or cost of healthcare in the United States. Dialing down a little bit more, this is also a very telling slide. If you do this sort of average of comparable countries, that's the blue line here. Again, the life expectancy is generally increasing. But if you look at the green line, which is the United States, it's also increasing. But if this was a Kaplan-Meier curve, you'd be a little concerned about the fact that they are separating as time goes on. So in addition to the fact that, yes, life expectancy is increasing in general throughout the world, our life expectancy is not increasing to the same level or the same rate as other countries, comparable countries. So I think we still have a problem. So we have a problem from the standpoint of the cost and the cost that we are being asked to bear in this system. And then we have a problem with the life expectancy as a payback to that. There have been some successes, though, and I have to put a couple of cardiology slides in here. And this is looking at the heart disease and stroke statistics from the AHA. And, since 2000, there's been about a 20% decrease in cardiovascular mortality in the United States. So there has been a benefit, but it's not across all the population. This is just cardiovascular disease. So some other slides to give you a little bit more of a foundation about what this really means in practical terms. In 2005, and this has been looked at from time to time, added about the cost of health care for GM, for example, about $1,500. When they looked at Ford, it was more expenditure for healthcare than the metal, the steel that goes into the car, and with respect to healthcare costs. It's about $71 per worker per hour. That's a huge number. Just think about that. Every hour. In Japan and Toyota, it's about half of that, almost. So what has this been driven by primarily? I'll get into more detail here in a moment. There's a disconnect a little bit. Physicians, at least to this point, have been paid for the services that they deliver. If I read an echo, I get paid. If I read an ECG, I get paid. If I see a patient in clinic, if I do a cardiac catheterization, I get paid for each one of those procedures. Hospitals, as I said a moment ago, different. Prospective payment system, the PPS, you get paid for an episode. So if you come in with a diagnosis of X, you get paid a certain amount of money for that diagnosis. Again, there's a malalignment between what the physicians are getting paid, how they're getting paid and reimbursed, and the hospitals. There's a problem with variations in care, which I'll touch on. And then at the end of the day, at least until more recently, there's been very little connection between the quality of the care that's being delivered and the cost of that care. It's just been, you tell us how much it costs, we'll pay that. And again, there's a conversation now occurring, it's been occurring actually for several years around tying quality to the cost of the care. So, do we know what the cost of care is? I get these questions all the time. My patient doesn't have any insurance. How much does it cost to have a TAVR done? Okay, so this is an interesting thing. This is interesting. So this is a hospital in Wisconsin, and their charge for a total knee was $50,000. And they've got a little concern because they got a little feedback from the people who pay the bills that we think that's too much money. But the reason it got to be $50,000 is, and I've sat in meetings in hospitals with this exact conversation. We're going to increase our charge master by 3 to 4% per year, period. It's got nothing to do with inflation. We're just going to put it out there and see who pays that amount of money. It's not based on anything. And so that's like compounded interest. It winds up at $50,000. So they did a study. They actually had industrial engineers come into this hospital and look at exactly what it cost based on the time, procedures, et cetera, and that cost was about $10,000. That's what it actually cost, although the charge was $50,000. And if you do a discount on that, let's say it's half of that, the insurance company is going to pay $25,000. But it didn't cost but $10,000 to produce that. Now, if you go to any hospital and say, how much does it cost for X, they will struggle with this number because they don't really know. Because this is how you get to these exorbitant amounts of money as the cost of providing that care. And again, if you have insurance, your insurance company is not paying that cost. What's driving the cost? This actually comes from University of Washington. This is from the IHME group here. It's actually an interesting article if you're interested in this subject. It's in JAMA last year. And this tried to look at they broke it down into 5 things that might be driving the cost. Things like population size, the age, the disease prevalence or incidence, service utilization, how many clinic visits, how many bed days did you do in your hospitals, service price and intensity. And in this period of time, between 1996 and 2013, the delta there in that change in the cost of care was over $900 billion. So how much of it came from the different parts of this? In general, if you look at the different diseases, it does vary some. Diabetes, for example, cardiovascular disease is slightly different than this, but this is the overall results of the study. Certainly, as the population increases, we have more people, that drives some of the cost of healthcare. We're aging, that drives some of the cost of healthcare. Interestingly, the prevalence and the service utilization didn't really drive the cost of healthcare here. But what drove most of this, almost $600 billion of the $900 billion, was service price and intensity. How much you're charging for each service and how much of that service you're providing. That's what drove about over half of the cost during this particular period. So this argument that, hey, we're getting older, there's more of us, that is important, yes, it does drive part of the cost. But the thing that drove most of the cost here was, again, the services being provided and the intensity of those services. So every time I give a talk like this or have a conversation with physicians, they want to bring up the fact, well, you know, the reason the cost of care is going up is because we are practicing defensive medicine. In other words, we don't want to get sued, so we're going to do everything we can think of in case, so we don't miss something. Defensive medicine. This is a look at that. course, it's from a law journal, so you kind of be a little biased perhaps, but there are other studies looking at this. And this is in Texas. And if you look at the circles, that's overall Texas. And in 2003, Texas passed significant malpractice reform where they capped non-economic damages to $250,000. And they did this study to see if that had any impact on procedures performed. See, for all of Texas, no, it didn't change. It actually went up a little bit. If you look at El Paso, went up a little bit, did not go down. You'd expect if this was defensive medicine, if you passed reform, it would go down, correct? And then, McAllen is sort of the poster child for variation in delivery of health care. Same state, boy, it didn't have anything to do with it at all, and a lot of variation in care between El Paso and McAllen, Texas. So it doesn't appear to be related to practicing defensive medicine either. Variations in care, I'll go through this really quickly. Again, back to a cardiology example of this. This is looking at PCI, and I just picked this. This is from the Dartmouth Atlas. I just picked a couple of the different states. I'm from Alabama originally. Mid 2000s, there was a lot of PCI. This is rates of PCI per thousand. It's inpatients. Over time, as we've developed evidence, I think, and better treatments for patients, medical therapy, et cetera, that has come down, but there's still a difference. And if I blew this up, you'd see that there's about a 1.5-fold difference between the lowest in this particular analysis versus the highest per 1,000 rates as well. And you could argue, if you look at that there may be a difference between the population in Alabama versus the population in Washington State. There probably is. When I can tell you, when I came here, it was palpable, the difference in what I was seeing in the cath labs with respect to atherosclerotic disease. So there is some difference here, but does that difference really explain this variation in care or not? I don't think so. So who's to blame? Well, this is perfect. The government, lawyers, businesses, insurance companies, healthcare providers, or the consumer. Consumers are coming in and say, I want that Repatha I see on TV. That's a joke. They're not driving much of this. I'm not going to go over this for the sake of time. Oh, I will go over this actually. So in I will go back to the Clintons. The Clintons tried to change the way we deliver health care in the United States. Were unsuccessful. This is in 1993 when Hillary Clinton was involved. And I had the opportunity at that point to go to a meeting, and I was in Alabama at that time. And the CEO of Blue Cross Blue Shield of Alabama, there was all this conversation about HMOs and what was Hillary Care and all this kind of thing. And he said, I don't care what you call it, I just want to remind you who my customer is. And some of you in this room have heard me say this before. Who his customer is. It's not the patient. Who is it? It's the people who are buying the insurance. It's the employers. It's the Microsofts. It's the Costcos. That is their customer. And they're going to give product to that customer that allows them to be successful. They are selling a product. So if it's an HMO or if it's some kind of discounted service or what do you want to call it, they're going to come up with something they can sell to these companies because that's what they do for a business. So it's not about the patient. This also comes up, why can't Mr. Smith have his TAVR done here? It's because we don't have a contract with that company. And they're not interested in giving us a contract for whatever reason, our cost, whatever. But the point is, their responsibility is to whoever's paying that bill, and the bill for that insurance for that particular patient is not coming from, by and large, not coming from the patient, it's coming from their employer. So they're going to protect their employer. I'm not going to show just to tell you, there was a couple of things, and I'm just going to put this up here for just a second. There's Harry and Louise, back in the early, in 1993 when the Clintons were trying to change things. Harry and Louise were saying, you can't do this. You're going to force us to, you're not going to take our choice away. You're going to force us to pick from a few insurance companies. That's not right. Fast forward when they started talking about Obamacare or ACA in 2009, Harry, same actors, they've aged. They're talking about, well, we've got to have pre-existing conditions covered. We've got to have access to care. It's the same people doing the acting, but different people are paying for the acting. And so the message is different. This is very interesting, but again, I won't go into it in detail, but Jimmy Kimmel who I'm sure most of you know, went to the street and asked people about the ACA and Obamacare. Most of you have sort of seen this. And it ranges all the way from, yeah, we like ACA better than Obamacare because ACA is Affordable Care Act. It's more affordable than Obamacare. You realize it's the same thing. This lady right here, well, you realize that that Obamacare is going to result in our guns being taken away from us. And she said, absolutely. I'm not kidding. And at the very end of this little vignette, there's a lady, and they walk up, and they say, hey, you know the ACA and Obamacare are the same. You know what she said? No, you're kidding me. You're trying to make me look stupid on TV. So how do we get to where we need to be when we have a public that's uninformed or misinformed? But again, you go to YouTube and look it up. It's actually quite interesting. Make sure I'm not running too long here. So just to remind you, the Obamacare or the ACA had 3 primary goals: affordable health care, in other words, including more people; expand the Medicare program, although that's a state-based program, so not all states had to do that, and not all of them did. But lastly, and most importantly, and we'll come back to this in a moment, support innovative medical care delivery through different methods of paying for that care. And this comes back to that quality or value-based care notion. Did it have an impact? It sure did. This is in 2010, about 20% of the population was uninsured. It's cut in half. So it had an impact in getting more care to more people. So go into how do we get paid. As I mentioned a moment ago, hospitals get paid a fixed payment. There's some adjustment for severity of illness and outliers, but it's basically a fixed payment. Where are we on that list of Medicare? This is Medicare payment, the average reimbursement per Medicare beneficiary. We're number 45. There aren't many things in the state of Washington where we come out number 45 in the cost of delivering care or anything else. But we're down here at about $9,000. New Jersey's $12,000. Does that have an impact? You bet it does. I won't tell you what program profitability this is, but this is our own internal data here. This is all payers, commercial insurance, Medicare, Medicaid. The profit in this particular group of DRGs is about $1 million. If you look at Medicare, it's almost a $3 million loss. So the way this all gets balanced is your commercial rates. If you have a low number of commercial payers in your sort of portfolio and you've got all Medicare, you're going to lose money on that patient population. So the fact that we get reimbursed at a very low rate for Medicare in the state of Washington is actually hurting our ability to take care of some of our patients. What impact does this have? This notion of no margin, no mission. This is MD Anderson. They had a tough financial year. This is Sutter Health. Profits plummet 80%. This is the Brigham and Women's. They, again, bought out 1,600 workers. This is the Cleveland Clinic. Now, Cleveland Clinic's still making a profit, don't get me wrong, but their growth was significantly impacted by a lot of this. And then you've got St. Joe's, Q1 loss. You've got Swedish here locally, who laid off 550 jobs. They need a more cost-effective model, is what they said. So this is having an impact. These changes in reimbursement, particularly Medicare, as we age, are having a significant impact on the financial viability of hospitals. This looks like, this is, again, go over this pretty quickly. If you look at just the hospitals in the United States with negative margins, however you want to define that, it's about 20 to 30%. So 20 to 30% of the hospitals in the United States have negative margins. If you have a negative margin, you can't buy the new cath lab. You can't build a new clinic space. You have to have that money to be able to use to provide the care. So what's the problem? Downward pressure on revenue, as I said a moment ago, led mostly by Medicare. Private payers, though, they're paying attention. As I said, that 1990s Blue Cross Blue Shield reminded all of us who their customer was, not the patient. Private payers, there's about 4 companies in the United States have over 80% of the business, and it's a business. And so if everyone else is decreasing the cost and they've got to go to Microsoft to sell the product that they have, and Microsoft won't pay whatever it is, then they're going to decrease the cost because that's their business that they're in. So the commercial business is also involved in this. As I mentioned a moment ago, what we've been paying for equipment, pharmaceuticals, the workforce, et cetera, are increasing as well. But if you have revenue, downward pressure in hospital revenue, and you've got increasing costs, that's when you get these negative margins. However, the top insurers are doing pretty well. These are the margins, operating margins of the Aetna's, United Health, et cetera, and it's about 5 to 8%. So they're doing pretty well. And they're going to continue to do well because, again, the customer is the business. If they're a private insurance company, their fiduciary responsibility is to their shareholders. It's not to the patient. So what about closer to home? What about UW Medicine, the impact? I just want to share this with you. I don't want to dwell on it too much. We've got a problem here within UW Medicine. If we don't fix our problem, that blue line on the bottom is going to be a big problem. So now we're trying to improve our financial performance across the system so we can get back up to a profitable situation. So about $278 million of improvements over the next several years. We need about a 2.5% positive margin in 2020. And as Rob alluded to, this is kind of where I've gotten involved, looking at the price of the products that we purchase across the system to try to impact this as well. So FIT, again, I'm not going to get into a lot of detail here. It's really designed to change the way we look at things. We've operated as individual hospitals. We're now going to have to start operating as a system to try to bring pressure to bear on the providers, for example, of the products that we buy. Again, it supports UW Medicine's overall goals. It's not a standalone project. This is not, we're going to do this for the next 2 years. This is going to be a new way of dealing with the way we deliver care in the system. It's got several different initiatives. There's revenue growth, there's a cost savings piece, and there's some infrastructure here as well. So it's not just the cost of things that we do. It's improving access. It's looking at getting paid for what we actually do, also very important. Turning our attention now to current and future payment models, and mostly around physicians. Okay, so as I said a moment ago, fee for service, RVUs, we do an echo, we get paid a certain amount of money, the physician does. It's for the volume of services delivered. It's not a per diagnosis reimbursement. The future is going to be value-based care. And this Medicare Access and Chip Reauthorization Act called MACRA is something, if you haven't heard about, you will be hearing more and more about, because it's the way that Medicare is looking at this. Quote the HHS Secretary in April, "There is no turning back to an unsustainable system that pays for procedures rather than value." So this is real and coming. The old model, we used to talk about the sustainable growth rate as physicians. We didn't like it, get rid of it, Congress. Congress got rid of it, and guess what we got? MACRA. So I'm not so sure we got a great deal in the difference here. The reason for that is that Congress was not, kept kicking the can down the road, and we were going to have to pay back 25% of our, physicians were going to have to take a 25% pay cut in order to balance the budget in Medicare. So that was the reason, one of the reasons they changed it. And so now we're going to talk about the quality payment program. And that, again, very complicated, like most things in the government. But MACRA has replaced this sustainable growth rate as a way of compensating physicians for their services. MIPS, again, what that stands for, but I'm just going to use the acronym. MIPS, 4 weighted components. Quality is the most important. As I said a moment ago, we're going to start being paid for quality. Resource utilization, how much stuff we're using. Clinical practice improvement, and then use of electronic health records and other more modern technology. There's a composite score there. There's an adjustment to reimbursement. It ranges all the way from -4% in 2019 to +4% in 2019. In the next 3 years, it's going to go up to about 9% plus or minus. So we are at risk. We can lose reimbursement or we can gain reimbursement depending on what that composite score comes out. Where this is all headed as the last bullet point are these advanced alternative payment models, or APMs. And this is sort of like, if you've heard of bundled payments. In other words, you come in the hospital, you need bypass surgery. It's a little bit like what the hospitals have been paid before. We're going to give you a lump sum, provide that service in the first 90 days after that service. That's all you're getting. Physician fees, echoes done, ECGs done, bypass surgery, you're getting a fixed fee. That's called a bundled payment. That's going to become more and more important as we go forward. It will be tied to quality, though. It's not just about paying you a certain amount. And there's a downside risk. If you don't meet, if you charge more than what they're willing to pay, or if your quality is not where it should be, you're going to get a negative consequence to that. You're not going to get paid what you think you should be paid. How is it here within UW Medicine? You haven't heard a lot about MIPS here, primarily because it's been focused more on ambulatory care and primary care, but it's going to be coming. And as I said a moment ago, the plan is to move to APMs. And we did successfully submit to the government, and we had a successful submission, so we didn't take a loss on these particular parameters. But this is not just CMS. The Washington State Healthcare Authority, CMS says that they want 50% of their reimbursement to be value-based by the end of this year, and they're moving to higher than that over time. 90% HCA, Washington HCA by 2021, and CMS is actively encouraging the private payers to get involved in this process as well. So this is the last slide. Where are we going? I don't know, but it's going to be different than what we've done over the last number of years. I think it's likely to get worse before we're forced to make meaningful change. Do I think universal health care is coming to this country? I don't think so. We've been trying to do it for 100 years. Unless things collapse, it's probably not going to happen, but we're going to have some variation on what we've been talking about. We need better alignment between hospitals and physicians. That's coming. Again, bundled payments. I'm paying you a certain amount of money for bypass operation, hospital, physician, the whole thing. It's going to be tied to quality, as I mentioned. We need to uncouple, I believe we need to uncouple healthcare from employment. Again, it had a reason a century ago to do this, but we're not in that same reason now. We have to have a productive and healthy population, and also healthy and productive employees as well. So we are moving from this no mission, no margin, this getting paid per unit, to no outcomes, no incomes. In other words, this value-based proposition, that this is about delivering value for the cost that's being paid as well. And again, this is this MIPS and APMs piece. So, but I guess half full, the glass is half full kind of guy. Is this going to bend that cost curve I showed you a minute ago, that percent of GDP that's now 20%? I'm not so sure. We're all a bunch of smart people. Every time they change the rules, we figure out a way to maximize our reimbursement. Again, this is not going to meaningfully change it, I don't think. I think it will have some impact, but I think given time, we'll figure this out, just like we figured out how to document the medical record when we see a patient in clinic, the things that we've got to put in there to get a certain level of service. We figured it out. We're going to figure this out too. So I think we're going to get back to this conversation about universal health care, but I think it's going to take, again, that GDP gets to 50%, it's not sustainable. We can't compete in the world if we're paying that much for health care and we're not getting the value for the amount that we're paying. With that, I'll go ahead and end, and I really appreciate everyone's attention. I think we may have a time for a few questions, but again, thank you very much. Questions? Yes, Rob.
So I'm going to go back to one of the slides that was sort of about a third of the way through, where you were looking at, well, what is responsible for the dramatic increase in costs in recent years. And it's always been confusing to me because the U.S. has sort of taken an approach to control healthcare costs by trying to reduce the cost of each individual unit, as opposed to the rest of the world, which limits access to getting widgets. And so, does it cost more for something to be done here in the U.S. than Canada across the border, or is it just that Canada has put in barriers to get to the cap?
That's a great question, and the answer is yes, it costs more in the United States. Pharmaceutical prices are higher, stent prices are higher. I mean, someone gave an example of this. They were having a conversation with somebody from Germany, and the cost of that, the stent came up. Ours is about $900 per stent, and they're paying like $200 or $300 or $100, some number you cannot believe. And they were astounded that we were paying that much money. So, in answer to your question, it costs more in the United States, yes.
But those aren't that idea that the U.S. essentially funds pharmaceutical and device for the rest of the world. That's not necessarily under our control. So, are we going to be able to push down costs to what the government?
Well, there is conversation within the current Congress around pharmaceutical prices. We'll see where that goes. But I think the other thing about your question, too, that needs maybe a little bit more of an answer is the way when we cut the price per unit, we just do more units. And that's the problem in the United States, I believe. And again, that slide sort of alluded to that. It's the intensity of the services being delivered, not necessarily how much each one costs, although that is important. But if you have a system which there's no feedback loop, if you think about this, and all you're going to get is volume over here, and there's no feedback loop to that volume, it's only human nature. If someone's going to say you can't do that much, and they cut the price, you're just going to do more, right? That's what happens. That's what's happened over all these years. So we have to have a fundamental change in the way we deliver healthcare and the way we pay for it. Because if we're just going to do unit-based volume, we're just going to do more volume, which is alluded to. If you look at Texas, that's what happened there. Yes, sir.
Yeah, great talk, Larry. So what's the model through which employment gets uncoupled from healthcare? I mean, if you're an employer now and you drop your healthcare benefits and you go out looking for employees, you're going to have a tough time.
Mm-hmm. Well, you know, it's going to be, as I said, I don't think it's going to happen because there are too many players. Unions, the companies who want their employees to be able to work. I think that if you did something like Switzerland, you know, Switzerland's got a higher cost, but they have really good outcomes, at least for life expectancy, where you basically mandate that you as an individual have to have the insurance. And you give that ability for that person to buy that insurance. And if he can't afford it, then it's subsidized by the government, but it's not all subsidized by the government. It's probably most palatable to the United States, but it would take a monumental shift in perception to get even there. But to go to completely universal health care where we're all paying into a system and everybody's got access, I think that's going to be very difficult to do. But a public-private solution might work. Yes, Jeff?
How accurately will we be able to assess quality, since that is going to be, at least if we follow the algorithm you're talking about, that's going to be the primary driver?
That's a great question, and it's difficult. What's being used so far are things like rates of ACE inhibitor use in heart failure, treatment of blood pressure, treatment of hypercholesterolemia.
So I take as the example, you know, you sit on an endpoints committee in a trial,
Mm-hmm.
and you know that this person has heart failure, but the data you presented does not fit the algorithm for assessing the idea as, or the diagnosis as heart failure. So I think there's a substantial parallelism here that's going to be difficult to circumvent.
Well, I think the other thing about this is that when you look at the macro level, which is what I've talked about here, it all kind of it does make a little bit of sense. But when you get down to the on the front lines kind of level, a lot of this information is based on billing codes and procedure codes and things like that. And in an individual, it may be that there's a reason that person's not on an ACE inhibitor, it's just not in the chart, for example. So I agree with you. There are some sticky pieces to this to make sure. But from a macro level, if I'm the government or a company paying for this, it does make some sense. Yeah, Jim.
Along those similar lines, I'm just reminded about the reporting requirements in New York in the late 90s and the impact on the surgeon deciding not to do surgery on people from lower SES strata of society. How do we avoid this from happening in a value-based system? Probably the best way to improve your outcomes is actually not to do
exactly. It's a good point. I think the difference, perhaps, is that it's across the country. So if you are if you risk avoid New York, you're not going to be able to go to Michigan necessarily. Now, the argument you would make is maybe we're going to under-treat patients. So I think we have looked historically at over-treatment. I think the argument that we need to make when we go forward with this is that we need to make sure we're not under-treating people either. Most all of what I talked about is potentially over-treatment, at least some of it, but we got to make sure we don't under-treat people either. What happened in New York, I think, is a good example of that. If you nationalize the approach to this and you have mechanisms in place that you can look at under-treatment, that's a quality outcome too. I think that's how you take care of it, but we've got to get to the point where we're not looking at overutilization, but we're also looking at underutilization. But we'll see how it goes. I think it's going to start with the easiest thing to do is to cut the overutilization. Trying to deal with underutilization is more complicated. Anything else? Okay. We got one more. I think they're making noise. Can I just talk? I'll get with you later.